Yeah? So what we've done, we made a little hole here. We've screwed the trocar in, and then we put the camera down, and I can now see within the dog's abdomen. So what we've got now is an inflated abdomen coming up to about 10, and if I put the camera down, because there's a light source at the end, I can see the light source on here. So I work out where it is that we want to make the hole into, and we basically triangulate so that we can get to the ovaries. So I'm going to come in about here, and if you want to be really uber cautious, you can use a needle, and we'll shove the needle through the abdominal wall, which I will see there. I can just see it behind that fat. Okay, so I know that's the right spot. And what I'm then going to do is make an incision about there, and I'm going to shove a hole through here, okay, through the abdomen. Then I'm going to use my bits and bound scissors to make that hole bigger. Excuse me. Okay, put your finger at the top. And then I'm using the larger of the trocars, basically to shove it through the hole. And because I know what I'm doing, it's come through there, right? So it just comes out, but we can visualise that. Okay, then what we have to do is very carefully point the camera caudally, so I'll make sure I come up, so I don't want to poke anything with the end of my camera. And what I'll then do is shove it in the direction of caudal abdomen. Now on the screen I can see that there's muck, and that's because it's got fat on the end, so I can just rub it against a bit of intestine. And then what I want to do is keep the camera looking upwards so that on the screen I can see. And again, I want to triangulate because I've got two instruments that are coming in, one from up here through this hole and one through here, which is this trocar down here. And we need to be able to choose the selection so that they're close enough so that we can get to the organs, but also far enough away so we can triangulate. If you're literally on top of yourself like a pair of knitting needles, it's a real challenge. So what I'm going to do now is basically I can see on here where the abdomen is. Okay, on the screen I can see my finger poke, 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 and I'm going to attempt to put a hole in the centre, which it is there. Okay, I don't always do this, but it does give you the information to be able to know that you're not going to stab it in the bladder. Okay, so I'm now going to make a little incision through the skin, just a little one. Okay, so let's stop myself there. Then what I'm going to do is go straight through the abdominal wall, okay, through here, which I've done. But you can't see it on the screen very easily because it's such a fine blade. But basically it's a small hole. To make the hole bigger, I use my Luxembourg scissors, shove it in, open it up. Okay, then just, it farts a little bit. Okay, and then making sure I'm going in the same plane, you then want to screw the hole through. And because these Stort's kit is so good, the end of it will catch the lip, normally, of the instrument, so it should. Because I'm trying to make the hole so small, this is probably that I haven't gone in the right direction. So I can see it bobbling underneath the skin. I might just make that a little bit bigger. Sometimes I get a bit cocky. So make that hole a little bit bigger, like that. Obviously it's massively magnified. Okay, there we go. It turns out I'm absolutely rubbish at this. Sometimes you can make a bigger hole. So what I just need to do is just catch it. It'll be the direction I'm coming at. Almost there. Come on, play the game. No. Sometime later.
20 years later.
Okay. So here's what I prepared earlier. Come on. very dark in here. There we are, okay, so we're through. Okay, and it just picks it up on the end, okay, because it's so bright, you get reflection a lot. Okay, so now we're in, all right? So what we're going to want to do now is to rotate the patient so that we can then get all the abdominal contents out the way, so that we can then get just visualise the ovaries. Okay, so what we do is we put the instruments out the way, okay, because these are titanium, which means they've got basically they've got a screw on them, they won't fall out, which is quite important. So now we just gently but carefully rotate the patient. So it's in a V-shaped operating table, okay, and we've got the legs tied normally under here, okay. We're holding onto the patient, and so what we're going to want to do is just gently roll her so that she comes in, okay. And we have to do a spleen shake. So the spleen sits up here and often gets in the way. So you give everything a good shake, and then it will rotate over. And we'll just put our hand underneath to put a tie on her leg to hold her legs from flopping and getting in the way. And the other thing that we'll do is we'll bring her over to the edge of the table, being very careful obviously so she doesn't fall off. That wouldn't go down well. And then what I want is this lower limb here to be pulled out the way. When we put the instruments in to grab the ovaries, then you want to be able to put the instruments nice and low so that you can get the ovary nice and high to keep it away from the abdominal contents. And if this leg is in the way, then it means you can't get the instrument low enough. It's not normally an issue at all. You just have to carefully move her. Alright, okay, so now we know that she's in the right spot, because we've done lots and lots of these. Can you just break that for me?
Sorry?
Because we've done lots of these, normally we can confidently place the camera back to this middle port, and we have to remember to push this button so it opens up. Okay, and now on the screen, we might want to just turn the operating lights off because it's difficult to see. We'll play this on the thing, but we can see her kidney here, okay? Because I know where I'm going, so I can see her kidney. I can see her uterus here. I can see her ovary here, nice small ovaries. This is fat. And then going back caudally, I can then see her bladder, bowel, a bit more uterus. So what we use now, a Babcock forceps, and my assistant, Debbie, will hold her here, okay? So what I'm doing, I'm pointing one of these trocars in one direction, okay? And I'm using this other one to point in the same direction. And I'm trying to picture in my mind where I'm going to end up. So I open this little bit so I'm not pushing anything, make the instruments last longer. And what we can see on here now, if we're careful, we can see the trocar there, hopefully, no, you can't. So what I'm going to do, it's in that falciform fat, that trocar at the front, so I'm going to screw it in more. The reason I do that is that we just want to make sure that we don't end up with we don't want to end up having a difficulty to get to the ovary. So you can just see on that thing that trocar's now coming out the end. See how reflective it is? It makes it a bit of a challenge sometimes. So we visualise the instrument going over the top, heading towards the ovary, and I use my little pinky finger to open this up. Grab the ovary carefully, with my little pinky finger, which I damaged as a child, so it doesn't work properly. There was a kid at school that ran into me, and it really hurt. I've got a wonky finger now. What's that? Okay, so now what we do, we've got the instrument here which we can just turn on. This is our Ethicon Gen 11 generator. So it's an electrosurgical unit, which is dead clever. And it beeps and pops and whistles and things. And what we can do is we can close the end of this instrument, and it puts a current through it when I press the special button, and then there's a bit that will cut. So it's the only one that cuts the seals. It's like a Grenville. Okay, so I know which direction I'm heading in, hopefully. So hopefully I'll see myself coming in, there we are, to the edge of the screen. And I can wobble this bit at the end and hopefully not dazzle myself. So what we want to do... Oh yeah. Ow, bugger, I didn't record any of it. Okay, so what we're going to do, I'm going to go in. So I'm going to come under here. I can feel the ovaries in between my fingers. So I'm clenched it. I'm pressing the button. It's putting a current through the end. When it starts beeping at me and tells me I can do it, I'm just going to move the cutty bit through. Okay. It then goes ping, and when it goes ping, it means that it knows that it's actually cauterized that vessel. Now you have to take a few grabs at this. So press the button again. Only one that cuts and seals. Ready? Ping! Okay, and then what we do is just twist this instrument here just to make that top bit just in there. So I can get underneath this. And I'm trying to get as much of the, well obviously all the ovary, and as little as anything else as possible. Because the less that we cut off, the easier it is. Can I just come in? So I'm going in there, grabbing that there. So the whole time we're looking on the screen to make sure we're not on the abdomen, because we want it, otherwise the end of this gets hot and it will burn the abdomen. So we just have to be careful. Also make sure we're not cutting the kidney, otherwise you'll damage the kidney. And I'm just going to, this last bit, okay, so I've probably taken a bit less than I normally, sorry, a bit more than I normally would have. So, talking. Last bit. Okay, so that instrument comes out there, chuck that up there, and then what I'm going to do is basically look at the exit bit, and then get that coming out through there, if we can. Now, in this situation, I'll twist it. If I twist that there, I should be able to screw it out through that hole. Other way. Okay, so then I usually fat belly to pull it up, and we just untwizzle this bit. That's it. Okay, it's obviously filling that hole up. As soon as it's done, the abdomen goes down, so I shove my finger over the end of it. And we just check to make sure that that ovary is in one piece, which we can feel. We will double check that. The instrument comes out. I've got my finger over this bit to fill this hole in. Okay, and we just connect it all up again. 1, 2, 3, done. Okay. And then obviously we need to rotate her again so we can then get to her other side. So keeping everything sterile, excuse me. Put that on there. And then what we'll do is we'll just flip her over again on the other side so we don't lose her. Okay. 1, 2, 3. Okay, so we're going to lower this V-shaped operating table down. We're just going to rotate her over. Gently but constantly under control is the plan. Okay. Now she's only on her side at the moment. I need to make sure that that spleen gets out of the way. So I'm going to bring her over gently. Just give her a bit of a wobble. And she should then be right. Okay, and then someone's going to come around and just grab that leg so that we don't get her on the other side. Then we can just pass that and hand it backwards. Okay. So what is going to be one relatively quick spray is then going to be like about 20 hours worth of editing to transfer it. As soon as I know what I'm doing.
Is she alright then?
She's fine, yeah. She's fine. You happy with that? There's a leg there. Alright? Happy? Yeah. Okay, so we're going with the camera again. Let that dip. And just let that bit around the back there. Okay, so the instrument goes in, open the valve, have a look to see what we're looking at. Okay, now depending on where I twizzle this, it makes it look as if the ovary is at the top of the screen, but if I twizzle this back to where the camera is always pointing upwards, and we can see her ovary again, and sometimes you get this crap on the end of the camera, so you just basically wipe it against a bit of gut. Then we go in with our instrument, which is our right instrument, and this is the Babcock one again, which is the one that you can click and catch. Right? So again, hopefully I know what I'm doing now. So I should come up from here, but I'm clocking where I think I'm going to end up. Good. Right, so there we are there, and you can twizzle the end of this bit so that you can grab the uterus, sorry, the ovary. And the idea is that I'm grabbing a bit of it so that when I then pull it out through the hole, I know that it will come out hopefully as easy as possible. If you grab a rugby ball or a kidney bean in the centre of it and then try and pull it out through that hole, you'll struggle. But if you grab the end of the rugby ball, you can then pull it through that hole and it makes it easier. So, got my electrosurgical unit again. Hopefully I should come out from the here. Clearly I'm somewhere. Oh, there we are. There we are. Okay, so we're going to make sure we keep it away from our abdominal wall, and I'm going to come in here. Can you put yours just a bit lower, please? Thank you. And just rotate it into your left a bit. Excellent. When we go in here, okay, so I'm pressing the button. It's now thinking of cauterising that, and then I'm sliding that blade through. Wait for it to go ping. It's happy. I'm happy. And then I'm going under here. I can feel the ovary. When I clink it together, I can feel it. It's almost like an extension of fingers. So I can feel the ovary actually chunk between the end of the forceps. Ping. Now hopefully this feels like I've taken a bit less tissue around the outside. Okay, if you just rotate it to the right a bit. Nice one. Okay. Okay, what we got there? Is it done? Last bit. Alright. Okay. Now that bit broke off. That bit broke off, so I'm just going to visualise that, get nice and close to it with a camera. You can see the level of magnification, it's amazing. So that's that. And then what we want to do is visualise that camera again. Sorry, use that camera to look at that ovary. So look how close we can get. See how hyper-reflective it can be. We just want to hold that, screw that in the right direction. Okay, screw it in there.
Something went, hang on.
Okay, so what we'll do, sometimes we don't feel that we've got a really, really good grip on the ovary, and obviously what we don't want to do is drop the ovary. It can happen, so I've got another pair of Babcocks, which I can go in, don't worry, sorry. And what I'll do, I'll just grab the ovary there. That's right. What have you got? Have you got it?
No.
Okay. So
I think I was stuck on
I think you probably were. Okay, so grab the end of it, twist it around. You obviously I've got a really good grip of it, and you've got a really good grip of it. You can put quite a lot of tension. You want to twist. Okay, that's it. Yeah.
No, I haven't got it.
You haven't got it.
No.
Push it down then. Push it in and grab the end of it, which you'll grab there.
Yeah,
Close it up. Yeah, no, open it. Open.
I feel what I'm doing.
Okay.
Yeah, let me come out and see.
Okay. See how shiny it all gets. There we are. Nice. Yeah. Okay. So that's going to go in there. Got it. Twizzle away from me. Feels like it's going down the hole, so I'm going to let go. And I might just give it a bit of a prod. Nice. Yeah. Away it goes. Okay. So then what we do, once that's been removed by Lauren, which we've got out there, okay, we can then, everything's gone down obviously, so I'm going to shove my finger back in the hole. Happy with that?
Yeah.
Can you just pass the ovaries over to me so I can just triple check? Thank you. So I can feel the ovary in the centre of that tissue. There it is. Okay, and we check the other one as well, because ultimately it's the responsibility of the vet to make sure they're done. So that's good. You could, in theory, leave a bit of ovary behind, but I'm confident that's all there, and that's really important.
Smashing job.
Nice one. Okay, so now I'm confident that everything's fine. So what I'm going to do is I'm going to turn the gas off, please. That gets passed back. And then what we want to do is make sure that we are getting all these instruments out. And I'm going to hand everything back to Lauren. If you take the ends off these bits off, we want to get as much of that intra-abdominal gas out. So we'll gently recompress her. Gently, that's fine then. And what I'm going to do now is unscrew the cranial abdominal port. And because it's often within that falciform fat, we just need to make sure that we've actually not tied any fat or not inadvertently dragged any of the fat through. Okay, and we've got 3 equal holes. What we then do is use some, depending upon the size of the dog, I tend to use 3 metric PDS for this, in the intra-abdominal muscle, some monofast just underneath the skin, and then very often I don't put external skin stitches in, just because it all comes together so beautifully. The critical bit is to make sure that you're not tying any of the fat in, because the holes are so small that it's really easy sometimes not to be able to see what you're suturing. Alright, and then once we've done that, we'll show you.